Hello, my name's Ivan Bristow, and I am a fellow at the Royal College of Podiatry in London, United Kingdom. And I'd like to thank you for your kind invitation to speak at the Updates in Dermatology Practical Perils. And the subject of my talk today is a very, very common problem, all about Verrucae, but hopefully I can offer you some little bit of new insights into their research around their diagnosis and also into the management of Verrucae, which there's been some very interesting developments in the literature, and I hope to cover that in this presentation too. Just to disclose that I am a consultant for Emblation Limited in the United Kingdom. So, Verrucae, or plantar warts as we know them, very, very common. And what does the research data tell us? Well, 3 papers here have investigated the epidemiology of Verrucae. And as they report, as we're all well aware, they're very unusual before the age of 4. But where we see them most are in the school ages in the UK, what we call secondary school here. So from the age of about 10 to 18, where we see a peak incidence. And studies have suggested at any one time, around 22 to 33% of children will have warts. And that number drops quite considerably into adulthood to around 3.5 to 6% of adults having the problem. And this is based on research from 2009 and 1998. What's interesting is if you examine the risk factors for children, and this was undertaken in 2 studies a few years back. Why is it that children pick up warts? What are the risk factors? We talk about the risk factors for diabetes, but what about the risk factors for warts, for example? And perhaps there's a common misconception that swimming pools seem to be the main place where warts are passed between one another. But what these studies shown quite interestingly, they've identified 5 key points or 5 key risk factors, as you can see listed here: being Caucasian, having friends or siblings with warts, sharing shoes, being part of a large family, and also being male poses a greater risk than being female of actually developing plantar warts or Verrucae. Now, diagnosis we may think is quite straightforward, and most of the time it is, based on the history, based on the visual appearance of the lesion. It's purely a clinical judgment, although sometimes lesions can be a little bit tricky. As we know, there's no standard clinical test for the diagnosis of warts, and there's no sort of lab test that we can actually employ. And studies have shown quite consistently that the human papillomavirus is carried on the skin quite asymptomatically in many patients. And one recent study showed that in a patient or a young child with warts, family members too, taking swabs of their forehead, in this particular study showed that around 1/3 of family members will be carrying the HPV virus on their forehead, and this will be detectable, but they won't develop any lesions elsewhere. So carriage is very, very common. Now, traditionally in the clinic, when it comes to diagnosing plantar warts or Verrucae, we rely on a number of very simple tests: pain on lateral compression, the interruption of the plantar dermatoglyphics, and also by the location. And also when you debride a Verrucae, you'll see pinpoint bleeding as you take the tops of the capillaries off. But is there any other way which can be really helpful when there is doubt in terms of the diagnosis? Well, one of the tools which has recently been on the rise, particularly in the dermatology clinic, is dermoscopy. Now, the dermatoscope is a battery-powered device. It offers magnification of the skin ×10, and it uses cross-polarized light to illuminate the skin. And ultimately what this does, it allows visualization of structures which wouldn't normally be visible to the naked eye. And consequently, it's found its way into many aspects of dermatology, including tumor recognition in particular, and early recognition of malignant melanoma, for example. But also it's very useful for a number of benign tumors, particularly warts. Now, if a wart is debrided and a dermatoscope is applied, normal Normally it's applied using directly to the lesion using polarized light or through a gel medium. And on this slide here, you'll see a number of features. This is a typical plantar wart. The first thing you'll notice are the sort of reddy, browny, purple dots around the lesion. And these certainly can be picked up with the naked eye as small subcorneal hemorrhages. But looking to the center of the lesion, and you can see a different pattern. You can see like white circles with little red dots in the center. And I tend to call this sort of frog spawn-like appearance because that's what it reminds me of, but it's very typical of a plantar wart. And in each of the white spots, you'll notice there is a little red dot, and that little red dot is a capillary which is coming up very, very close to the surface. And consequently, this is why when you debride a wart, you just take the top off that tiny little capillary and it oozes to give you that characteristic pinpoint bleeding. But certainly dermoscopy can be very helpful in discerning a wart from a corn, for example. Here's another lesion. You can see again white circles, and this one's still got the subcorneal hemorrhages throughout the lesion, but it's got a very distinctive characteristic pattern which can be reassuring to the practitioner that the right diagnosis has been made. So what are the main wart types? The main wart types that studies have shown are HPV 1, 2, 7, 27, and 57. These are the most common ones we find on hands and feet. And the presence of black dots is the most predictive feature of plantar warts. This was a study which tried to determine whether you could tell the type of wart by the visual appearance of the lesion. And it used a series of photographs and test and retest methodology. But what it showed was that there's no real way to discern which type of subtype of the HPV virus is causing the lesion. And consistently that black dots are the most predictive feature of Verrucae. What it did show, though, it examined the treatment of the different subtypes, and it showed that HPV1, which you tend to find in younger children, so children at the age of 10, shows the best response to treatment. The other types tend to be more stubborn and more persistent and resistant to most types of treatment. Just to show you here, this is dermoscopy of a corn, and this lesion here, or a clavus, as you call it in the United States, this lesion here, you can see there are no dots present within the lesion. In fact, there are very few features in the lesion itself which actually give you any clue to it being a wart. Generally, calluses and corns are quite featureless in that respect, so they're very easy to tell apart from Verrucae. What you occasionally have to be aware of are new warts in older patients, because occasionally there are mimics of plantar warts. If you have an older patient and they're presenting with a solitary lesion and they're exhibiting any suspicious signs such as unusual features, spontaneous bleeding, malodor, oozing or hypergranulation tissue, changes in formal growth, then there should be suspicion to an alternative diagnosis. And particularly in the older age group, what we're looking at are lesions such as this. And this is what we call in the UK, this is verrucous carcinoma, more commonly known as carcinoma caniculatum in the United States. And this is a slow-growing malignancy, which can mimic a wart, although in most cases it doesn't, it always shows some additional features. As you can see here, it does look like a rather bizarre type of wart. These lesions very rarely metastasize, but they can be quite extensive, grow very slowly, and consequently, when it comes to excision, they can lead to quite sort of radical surgery, and often large areas of the foot can be amputated to ensure that they resect the lesion back to clear margins. But one to be mindful of in older patients presenting with a single lesion, which doesn't quite fit the normal pattern of a plantar wart. So what do we tell our patients, particularly the younger ones, about how quickly our warts will go? What are the natural resolution rates of these lesions? Now, there are a number of studies, and again, I'm just trawled through the data here to come up with some of the figures, but of those at warts aged 11, 93% will have none at the age of 16. So basically, the vast majority of teenagers, by the time they reach adulthood, should have shed their warts, regardless of whether they've had treatment or not. Now, a later study, this was published in 2013, looked at a large cohort of just over 1,100 school children in the Netherlands. And around 50% of the school children who had warts were found to be wart-free within a year. So that suggests actually that the resolution rate is much quicker than we anticipated. But this study also showed what we've known for a long time, that the younger the child is at the time of they acquire their HPV infection, the faster they will be to reach resolution. So perhaps it's better that children catch their warts and verrucae at a young age, which means ultimately that they will go quickly and they'll probably get longer lasting immunity. In this next study, published in 2018, this was just looking at young adults. So between the ages of 16 and 18, 19, and it was a study of 15,000 college-age students. And wart prevalence in this group was about 1.4%. The vast majority only had one wart, and the vast majority, again, were quite small, less than a centimetre in diameter. Even in this group, who are, if you like, older children or young adults in this case, about 50% resolved within 2 years. So collating all that evidence together, it suggests that most children certainly will be free of their warts within a year or two, regardless of any intervention that's undertaken. So very reassuring for the patients. Although, of course, other treatments or active intervention may speed this up. In adults, the picture is very, very, very different, as we know. And as the study here showed, it's not uncommon for adults to have warts for 5 to 10 years before resolution. So once the child becomes an adult and they're carrying their warts through into adulthood, they can be much more persistent and become much more stubborn to treatment. The reasons for this, we still don't know. There's some as yet undetected change within the immune system, but certainly it seems to be the case that whatever this change is, it really favors wart persistence. And that is an interesting question, because if we're going to defeat warts, we need to know why they persist. And finding evidence and data on this is quite difficult. A lot of studies have been carried out on the more high-risk HPV, such as the HPV virus that causes cervical cancers and so on, but less so on the humble wart that we see on the skin. But what we do know is that normally in the skin, immune function is very, very active, and clearance of warts is facilitated by primed T cells. These are T cells that have been directed specifically at elements of the HPV virus. And the T cells are primed by the antigen-presenting cells, or the dendritic cells in the epidermis, such as the Langerhans cells. So it's the Langerhans cells are the, if you like, local surveillance within the skin. And once they're able to detect the presence of HPV, in a normal situation, what they will do is then attach to the wart itself, to attach to HPV particles, and then present it to T cells, which will then prime and wart resolution takes place. But as we know, for so many people, it just doesn't happen, and things go wrong. When it does go right, this is a sort of pattern that you see, and you'll see here, this was a patient who I treated, and within a treatment, she was getting resolution. The wart became very, very itchy, and you can see here, she's got coagulation within the vessels, but this is a very good sign. And this patient, within 2 to 3 weeks, the wart had completely vanished. And this is what we hope for every time we treat a wart, but it doesn't always quite work that way. And HPV takes control of the whole cell, and it does that by essentially hijacking the normal DNA function within the cells of the epidermis. Now, the HPV has particular genes known as the early 6 and early 7, or E6 and E7. And essentially, when they're activated following infection into the cell, it's able to take over gene expression. And consequently to that, there are a number of other sub-factors which also take place, such as histones. Now, histones are, if you like, helper molecules that work with the DNA within the cell. And their job is to is to be part of the immune surveillance system through something called TLR, toll-like receptors. But once the virus has taken over, this histone function is switched off. So one of the mechanisms for alerting the immune system to the presence of wart virus is actually turned off. The other aspect is nuclear factor KB, which is blocked. And nuclear factor KB is a very important pathway which generates inflammatory cytokines, the cell signals which generate the immunity that we need to instruct Langerhans cells, T cells, and natural killer cells. But again, the virus is very tricky. It's able to switch off this nuclear factor KB and again suppress it. So effectively, it's in control and it suppressed the local immune response. So how do we actually take back control? If we have a virus in the cell and the virus is switching off all of the major control panels that we have to fight the infection, how do we break that? And what I'd just like to move on to now is just to discuss one of the principles of recent research, which is hypothermia. Now, hypothermia, as the name suggests, means elevated temperature, but it doesn't mean temperatures that sort of raise it to boiling point. What we're talking about here is a temperature around about 45, 46 degrees. So degrees centigrade. So just above body temperature. But when we hit this particular hypothermic range, just above body temperature, and we hold it at this particular level, we see some very interesting changes in the immune function, the dynamics of the cell. Recently, there's been a lot of research which has been looking at the effects of heating tissues. And heating tissues, as I say, between 43 and 46 degrees centigrade is called the hypothermic range. What it causes is a process which is non-lethal to the cell, but it's called heat shock. And when the cell is shocked by this level of heat, essentially it goes into a reboot. As the cell reboots, it produces a range of chemical signals called heat shock proteins, of which there are a number. And these heat shock proteins have some very advantageous effects on the immune system. Now, we know from previous research that heat shock proteins have multiple effects on various cells within the immune system. I'm not going to go through all of these, but essentially what it would do is to retune the immune system and to speed things up. It activates Langerhans cells. It makes them more likely to present antigens to T cells and other chemicals and chemical signals that are part of the inflammatory pathway that lead to the destruction of infection and HPV infection. It all moves in a very positive way. It also releases interferon, and heat shock proteins release interferon, which is the body's natural antiviral. So all in all, if you raise the temperature of the cell and do that quite quickly, you invoke this heat shock protein, but then you get all these benefits on the immune system. What do we know about this heat shock protein, that appears? Well, clinically, studies have shown that when you heat the skin to this level, you can enhance HPV clearance. And there have been 3 studies here that have all shown consistently, whatever method of heating is used, and there are different ways of heating the skin to this level, you will invoke HPV clearance versus control. And this was a study carried out in 2010, a little bit more detail, but there were 54 patients with warts, and they were randomized to a very simple heating device, which was placed on the skin to raise the skin temperature to 44 degrees. This was a very slow heat. It was about 30 minutes it was applied for on 3 consecutive days. But what they showed was that just with very simple heating to the hypothermic zone, resolution rates were 53% versus just 11% in the control group. And a study from the USA demonstrated a similar effect. Instead of using a crude heating device, a heat patch. And this cleared 46% warts in a cohort of patients. So using a slightly different method, but it still proved the same point. Research that we undertook at the University of Southampton and subsequently published in the British Journal of Dermatology, we used microwaves. Now, microwaves have a number of advantages over other ways of heating the skin, not least in the speed and the controllability and the calibration. It is a very precise mechanism. But essentially what we showed using skin explants was that by labeling certain cells of the immune system and exposing test tissue to microwave energy, even at low levels, we could detect a number of changes within the skin in a positive direction, effectively anti-HPV activity with just low levels of microwave heating in the skin. And this work was published in the British Journal of Dermatology. And what we found, and this was published in a second paper, the release of heat shock protein 70 from the tissue occurred when we exposed it to this microwave energy. And there were four main areas, as you can see here. To summarize them all, basically what they did was to improve the immune response. They woke it up and they basically unmasked, if you like, the latent infection. So switching on the Langerhans cells, increasing their ability to migrate and latch on to the HPV particles and present them to T cells, as well as localized interferon production. So moving everything towards natural immunity in a very rapid way. And just to show you clinically, this is a picture of a patient. She's 55 years old. I was slightly worried when I met this patient. She's a litigation lawyer, so I thought I'd have to go very carefully. But she had multiple warts. She'd spent many thousands of pounds on various treatments and nothing had worked. And this is her foot after she's had 2 treatments using microwave. And you can see there's some bruising evident within the lesions. But what she could tell, even after 2 treatments, that the pain of these lesions had gone down considerably. And that's quite a common side effect, if you like, of using microwave treatment. So after 4 treatments, I then reviewed her 3 months later, and this is what I found. She was delighted. I'm not going to get sued, which is good. And she's even told her friends, so likely to get some more referrals. But you can see there, what has happened is that the heating has caused the immunity to occur. But bear in mind, she'd have all sorts of treatments before that with very little success. And she found that the microwave heating was very, very quick, a little bit uncomfortable, but effectively cleared her warts where nothing else had done that before. So what are the advantages of using microwave clinically? Now, academically, as I just pointed out there are a number of effects in that you are using heat in a very rapid way, something called dielectric heating, which can bring about changes in the immune system. But clinically, when you're using microwaves, there are the added advantages of very rapid treatment time. Now, to heat a wart up to 44 degrees, for example, using something like a heat probe, that would take some time. That would probably take maybe 4, 5, 6, 7 seconds through conduction. With microwave, you're looking at heating time of less than 2 seconds. And that is the main effect that we can see, very, very rapid treatment time. So you can bring about that hypothermia in 1 or 2 seconds. Very easy to use. And the device is very, very predictable and repeatable because it's calibrated. And we don't use any anesthesia in the United Kingdom for patients undergoing microwave treatment. It is uncomfortable, but I would say it's a lot nicer than using cryotherapy, particularly in the ensuing days when the thaw takes place. But no smoke's produced because you're not vaporizing any tissues and you're not breaking the skin. So effectively, there are no post-operative dressings or special procedures that are needed. So from the biochemical side, it has an effect on the immune system, but clinically it also has many advantages to it. So in conclusion, what I've covered seems quite quickly, time flies, but verrucae are a very common clinical problem. And HPV infection is very clever. It can alter the cell's normal immune mechanisms by hijacking the DNA and the DNA processes that take place. And all of these then fall in favor of wart persistence. But the good news is that the recent evidence that we've published and also the work of others before us has shown that skin hypothermia, just raising the temperature a few degrees to about 43, 44, 45 degrees, can help to bring about heat shock and heat shock proteins. And heat shock proteins are the body's natural way to reboot the immune system. Ultimately, what that does is reinstate the natural immune cells, the T cells, natural killer cells, and Langerhans cells, leading to clearance of stubborn lesions. And more work is underway in this direction, and we hope to be publishing more microwave-based research on this very, very soon. So just to leave you with a few practice pearls, Verrucae are very common and warts are very persistent. Now, don't forget, dermoscopy can be very helpful in your diagnosing the verrucae, looking at the points that I've discussed, but always be careful of unusual solitary verrucae in older adults, which exhibit unusual features, and these certainly should be biopsied. As we know, there are a range of treatments available, but recently hypothermia as a treatment modality using microwave has shown some very good evidence for immune response enhancement. Thank you for your time today. I hope you enjoy the rest of the meeting. Please feel free to contact me directly with any questions. My email address is given there. And also I have lots more free information about everything podiatric dermatology at my blog, which is also listed there. But thank you very much.